Very much, Lucia. Can you hear me okay?
Yes, we can hear you.
Okay, very good. I'm going to jump right in. So thank you to all the organizers for having me. Today I'm going to talk about the intersection of COVID, climate change, and the medical supply chain. And how I got involved with this was basically during my training, which was so much fun, taking care of patients, doing anesthesiology. At the same time I was taking care of patients, I was using so much stuff, wasting so much stuff, throwing away so much stuff. It was clear that I must be doing harm somewhere else in the world, but there was no information about it. So, this is, I think, something that is pretty obvious to all of us who take care of patients, that we're causing a lot of pollution, and what can we do about it? So this is, I think, a unique form of ecological grief that we suffer. And that's why I do the research that I do. I made a pact with myself that I wouldn't continue to practice unless I tried to make a difference. So for this talk, I will go through a description of and hope that by then you'll be able to describe healthcare environmental emissions, discuss a scientific modeling tool called life cycle assessment, and give some examples of how it's applied to reusable and disposable medical devices, and identify some sustainability solutions that improve supply chain resiliency and reduce emissions. So why sustainability in healthcare? Pollution is a leading cause of morbidity and mortality globally. There's 9 million, or 16% of all premature deaths annually, are due to pollution. Healthcare itself is a leading emitter of environmental pollutants, ironically. And reduction of healthcare pollution can improve the triple bottom line, which is the best care for the most patients at the least cost. And supply chain risks has been made transparent through the COVID pandemic. The same risks apply whether it's COVID or climate change, and the same sustainability solutions also apply. And importantly, engaging health professionals around healthcare pollution prevention and supply chain resiliency can be a key for public policy and societal transformation. Globally, healthcare is responsible for 4.6% of global global total emissions. So that's a huge number, and this is from our work from the Lancet Commission on Climate Change and Health. You can see the US is an outlier. So we see per capita gross domestic product against per capita healthcare greenhouse gas emissions. And healthcare in the US, even though we are only 4% of the world's population, we account for about 25% of the world's healthcare greenhouse gas emissions. And these trends are rising over time. The one outlier here is Greece, and that had to do with economic disruption with the Syrian crisis. So obviously we can reduce emissions by taking care of less patients. That's not the goal. In fact, we have to increase access to healthcare and increase quality access to healthcare. And in the latest issue of the latest publication of Lancet Commission on Climate Change and Health, so this is from 2018, we expanded further to plot greenhouse gas emissions against the Healthcare Access and Quality Index from the Global Burden of Disease Project. And what we found was that there is only a correlation up to a certain point. So increases in healthcare can reflect increases in healthcare spending, and therefore emissions can reflect improvements to access and quality. But there's a certain point where that's not the case, and that's around 400 kilograms of CO2 emissions per person for healthcare. And if you look at this graph here, you see that you can have less greenhouse gas emissions or more with high quality care. So France, for example, has around 330 kilograms of carbon dioxide equivalents per capita in healthcare. Japan around 1,200, in the US around 1,700. So we're not even the best in terms of this index in terms of quality and access, and we're an outlier. So there's a huge disconnect, and we know that we spend more than twice as much on healthcare in any industrialized nations. We don't have the outcomes to reflect that expenditure investment. And so this is a recent publication that we just did that just came out in Health Affairs. We updated our prior work delving in specifically to the US healthcare sector and trends over time. And overall, the US healthcare sector emits 8 to 9% of our nation's greenhouse gases, and similar fractions of criteria air pollutants, which are both directly related to fossil fuel consumption. And again, our healthcare per capita emissions are the highest in the world. We're between 16 and 1,700. Per capita. And at the same time, as I mentioned, we have about 28 million uninsured. So we have to figure out how can we expand access and quality and reduce our emissions. Public health damages from healthcare have been estimated by us to be around 388,000 disability adjusted life years lost annually. That's especially from air pollution, but also from greenhouse gas emissions. And this is actually on the same order of magnitude as damages due to deaths from preventable medical errors. And why this matters is that there was a very famous report that came out in 2000 from the Institute of Medicine, now the National Academies of Medicine, called To Err is Human, that described the magnitude for the first time of preventable medical deaths due to health care. That sparked an entire patient safety movement. So now everything we do in healthcare is through the lens of patient safety. And what we're trying to say here is that pollution prevention is a new patient safety movement. We're talking about the same things. And delving even deeper into the US healthcare sector, and this is true in other nations and international studies, about 4/5 of emissions in healthcare are coming from the supply chain. So the pharmaceuticals and chemicals that we use, medical devices and supplies, and also food. And healthcare administrators and clinicians, and to a certain extent, regulators, we control the consumption of these things. We decide how much we use or don't use. And so we're responsible for consumption and waste. And manufacturers and regulators control what's embedded in the supply chain and what goes to marketplace. So these are our leverage points for where we can have an impact. So healthcare resource consumption, so just delving a little bit more. So 10% of the global economy is stemming from healthcare, and about 20% in the US, as you've heard mentioned earlier. Hospitals are very energy intensive. They have very specific requirements for heating, ventilation, air conditioning, and cooling, high-tech equipment that has to run 24/7, and diagnostic therapeutic equipment. We have unique conditions for infection prevention. That is specific to our industry. There's no other industry like it. Maybe the food industry kind of comes close, but not nearly to the same extent. We suffer from enormous regulatory complexity that's intended to help, but it's such a mammoth beast that it's actually driving a lot of waste and costs. And this is well known and described. And existing business models actually are part of the problem, driving disposability and waste and manufactured obsolescence. And then, of course, for those of us who are healthcare professionals, we see and we participate in and we observe on a daily basis that there's a culture of excess and disposability is normalized in developed countries, and particularly here in the US. And clinicians will be familiar with this. This happens to be a picture on the right of the core of the what's called the sterile core, where we keep a lot of our sterile supplies near the operating rooms that surround this area. And basically, you just pick and choose what you want. That we also get kits of supplies from the Central Sterilization Supply Department. But this is meant to show that there's no accountability in most of the supplies we use in healthcare, with the exception of very expensive devices such as implants for joints, for example. So there's no accountability. So it's this candy store culture, meaning everything seems like it's free. You can take what you want or not, and nobody will ever trace it back to you. And so it's not even part of our awareness. Now, infection prevention is essential in healthcare. It's part of the patient safety lens. Everything we need to do is through that lens. It's a big problem in the US, 700,000 healthcare acquired infections annually. This is pre-COVID. 75,000 deaths annually due to healthcare acquired infections, between 6 and 7 billion in excess healthcare expenditures. And if we fail to prevent a healthcare acquired infection, that not only drives up costs, it also drives up pollution and consumption of resources. So we have to, it's also our moral responsibility to prevent infections. But unfortunately, we go to the extreme in what we use to prevent these infections. It's driving this trend or the excuse toward disposability with medical devices. And I'll only speak briefly about drug waste, which is another big issue. So one type of infection that is very prevalent is surgical site infection. And this is a very illustrative photo graph that goes back, that tracks essentially the rates of infections going back to 1800. And if you had a major operation back then, you had about a 95% chance of getting infected and about a 40% chance of surviving for a major operation. And then along came Semmelweis and Pasteur and Lister and our heroes, which essentially they defined germ theory, they proved it with a microscope, and that started the whole movement toward antisepsis or aseptic technique. And that was the largest decrement we've we've seen in the history of medicine in terms of surgical site infections, and the greatest improvement in survivability after a major surgical operation. And then the next big decrement you see here between the 30s and 40s had to do with the introduction of antibiotics or antibiosis therapies. And so that's the next big inflection point. And then we have improved our processes and procedures since that time and protocols. And so now you have about less than a 2% chance of getting an infection and greater than a 95% chance of survivability from a major infection. So, but we're consuming more and more and shifting to more and more disposables. If anybody's set foot in the hospital, I mean, from blood pressure cuffs to pillows to complex surgical instruments, it's really quite outrageous, but it's all in the name of infection control. So here is the same part of that curve I just showed you of risk and infection. And as we're asymptotically approaching zero, we are throwing more and more materials and supplies trying to get to zero. We're ignoring this indirect disease burden that's coming from the consumption of all these resources. And we can't afford to do that anymore. We have to find the right balance. And so we also have to ask the question, is the goal of zero healthcare acquired infections realistic? Causes of infection are multifactorial. Big things have to do with staff discipline, antiseptic or aseptic practice, including hand washing, patient health status, whether or not they have diabetes or are immunocompromised, the exposure site, the quantity of organism inoculation, how virulent it is, and so forth, and decreasing order of impact now, that the most important thing that remains for us to do is to do a better job of washing our hands. Even here in the developed world, even where we have lots of waterless soap and don't have problems with access to water and clean water, we don't wash our hands enough. And so we are not going to solve problems with diabetes and hand washing by throwing more and more to disposables at the problem. That's not the solution to those problems. And now we have, as we've seen from COVID, it's really made us appreciate that we have a global supply chain. Materials come from all over the world. To even produce a single item, we'll have materials brought in from all different locations. And so usually we're lucky if we know the direct suppliers and materials that we buy, but is not really quite visible is where those suppliers get those materials and where those suppliers get those materials. And so any breakdown in the system can cause a catastrophic shock, as we've seen with the COVID pandemic and production of chemicals and PPE, mostly coming out of China. So globalization is great because it can reduce production costs. It also exports pollution, which is a question about justice. There's this idea of just-in-time delivery where we only get supplies when we need them to reduce storage costs and device expirations. But there's this, again, this lack of transparency in the supply chain that has left us vulnerable. And whether we're talking about COVID or climate change, it's the same idea. This has been made most apparent with COVID and PPE shortages. And this is not the developed world. This is the United States on the left-hand side, one of the New York City hospitals. And on the right, this is in the UK. And anyone who takes care of patients is quite familiar with this because we're using devices that were intended to be disposable. And similarly, there were shocks with Hurricane Maria. Now, it turns out that the vast majority of our drugs were manufactured on the island of Puerto Rico. So when it was devastated, it had enormous shocks throughout the supply chain here in the US. Some of it made the news, many of it didn't. A lot of people are aware that we had saline shortages. Less people are aware of something that affected my profession, local anesthetics. So spinal anesthetics, which we do routinely for women who require surgical delivery of their babies. Usually we use about 1.2 to 1.5 ml. So here's a 2 ml vial of bupivacaine or local anesthetic, but this was completely out. So we had to substitute a 30 ml vial and we had to throw the rest away. So this perverse situation happened that at the same time we have shortages, we're also throwing things away. And we were also seeing this with the COVID pandemic. And the only other thing I'm going to say for drugs, we could do a whole talk on this, is that there's a lot of contributing factors, including oversized vials. Vials are much bigger than we need. And that's, again, part of the manufactured obsolescence. There's regulatory requirements preventing us from splitting doses between patients, which is intended for safety reasons, but also has repercussions when it's overinterpreted or not necessary, certainly during a crisis. Obviously, we worry about contamination, but we also over-prepare and these drugs expire. And there was a great study just looking at cancer drugs that show we waste $3 billion a year in drug waste for these very reasons. And for me as an anesthesiologist, I'm the only specialty that routinely draws up and administers drugs ourselves. At the same time, you may recall a couple of years ago, this making big headlines was insulin shortages because of the dramatic increase in prices. People were rationing their own care, and there were actually a number of deaths here in the United States, and this still occurs because people are rationing their drugs. At the same time, we're throwing away 97 and 99% because we get this huge vial and use a very tiny fraction, less than 1% in the operating room. Very briefly, plastic crisis and surge. So 8.3 billion tons of virgin plastic since it was introduced to the marketplace in the 1950s. 40% of today's plastic ends up in the environment. Healthcare materials are routinely incinerated. We're running out of landfill. So a lot of even healthcare waste is ending up in the environment. Even if only 1% of face masks were disposed of incorrectly, it was been estimated that 10 million will end up in the environment monthly. And microplastics are another concern. I talked about that last year. Microplastics are ubiquitous. They are in our tap water, they're in our salt, and this is a global problem. So we really need to look at alternatives to plastic and consumption. So the Spaulding classification is used to define types of infection risks. So some devices need to be sterilized. Those things are called critical, that enter normally sterile tissue. Some things are semi-critical, meaning they touch mucous membranes, or for example, in our mouth, they need to be high level disinfected, but they don't need to be sterile because our mouth isn't sterile. And now non-critical items, things like masks, things like blood pressure cuffs, they need to be decontaminated or have low level disinfection, but they need not be sterile. We have to rationalize how we clean things. So this is just a very brief example. This is a laryngoscope, what we use to put in breathing tubes. On the left is a reusable version, on the right is a disposable. This portion called the tongue blade enters the mouth, so that is semi-critical because it is touching mucous membrane. The handle we just touched, so that's non-critical, but there was a loophole that was exploited that said, now you have to consider the handle semi-critical. It's controversial, but institutions were then immediately challenged to either go from cleaning the handle, which is non-critical at the point of use, to instead sending it down to the central sterilization supply department, which increases complexity of management. So you could either do that for higher level cleaning, or you could just go to disposable, and it's certainly easier to just go to disposable. And so life cycle assessment is a study. Basically we think of things when we use them. Sometimes we think about how they're manufactured, but if you go back even further, you have to consider the energy and material inputs at each stage, including material production, material extraction, production, transportation use, and disposal. So it's not just what we throw away. So in order to compare decisions, you have to understand the inputs and the emissions at all phases and add them together, and it's not necessarily intuitive. And even though we're talking about carbon emissions, it's not just about carbon emissions. So we have to make sure we're not just trading off one environmental catastrophe for another. And this is types of science is used to help with decision support. So we did a study looking at the reusable and disposable laryngoscopes. So the SUD single-use disposable. So we looked at the inputs from raw material extraction, manufacturing, packaging use, and solid waste management. For the reusables, the thing that we had to look at is how the things were cleaned, and that these things were used. They're rated for 4,000 uses. So that means we have to compare this against 4,000 cleanings for one device for 4,000 disposables. And then we looked at the life cycle cost, because it's not just the procurement cost, but it's also labor for cleaning and eventual waste disposal fees. And so there's a lot of information on the slide, but very briefly on the left, if you just kind of squint at it, the things that will stand out to you is that the gray is bars are much taller than the green. The gray represents single-use plastic and single-use steel alternatives, and the blades are on the left and the handles on the right, and these are different cleaning options. So the green is if we clean them and the grays are single-use disposable. So we increase the emissions by up to 7 times per device by going with the disposables. And one of the pushbacks we get is, well, you can just recycle them. Well, it turns out you can't just recycle them, but assuming that you could, if you could 100% recycle all those materials, which is not feasible, that's what this bar stands for. So the red is the waste disposal. So the emissions savings would be decreased by that much. So we cannot recycle our way out of this problem. On the right are the results of the costs. And just very briefly, we increased our costs by my institution, my department, which does about 60,000 intubations a year, increased costs by $700,000 a year by going to disposables. So we had no need to add additional labor to handle these devices, but we could certainly hire a lot more people if we needed to. So another example of PPE, reusable versus disposable textiles. This is part of our PPE, the gowns that we wear to protect us as we're taking care of patients, such as COVID patients. Disposable gowns, 2 to 3 times the energy, 2.5 to 3.3 times water consumption, 7.5 times solid waste consumption, which is the most visible, and 2 to 3 times the CO2 emissions. If we went to disposable versus reusable. So why not go to reusable? It's the same solution for COVID supply chain shocks, as this is one of the critical things on shortage. And some other thing to consider, and that has to do with the energy mix. So this is assuming US energy mix. Europe has more renewable energies, so there would even be lower impacts for reusables. In Australia, it's higher emissions for reusables because of their source of energy. So going toward more reusables is going to be have even greater demonstration of benefits. And so we have to ask the question, what is a disposable medical device? So the SUD, or single-use label, it's actually an industry creation. Just because a device has that label does not mean it can't be cleaned. What it means is whoever cleans it assumes the risk of its functionality. And what does reprocessing mean? It simply means cleaning the device, whether you do it in-house with your central sterilization supply department, or you go to an external third-party, what's called reprocessor or reprocessing. So taking single-use devices and sending it to a third-party reprocessor is something that's become common practice. Now, industry pushed back and said that's not safe. The GAO, or the Government Accountability Office, was commissioned to produce a report back in 2008 and basically found there's no increased risk from single-use device reprocessed by a third party as opposed to reusables. But unfortunately, only a small portion of our devices are clean. Now, what about COVID and climate change? So so these are more of the similarities. So we've had no choice out of desperation but to reuse these single-use devices. We don't have the infrastructure to clean them. We've actually had to struggle to get the infrastructure. Perhaps you've heard, under the Emergency Use Act, that we've figured out how to reprocess the masks and the gowns. And even I gave you the example laryngoscopes. Here's a different example, a type. It's a video laryngoscope for indirect laryngoscopy. So the disposable covers were always also on shortage. And what we found is that we can safely reuse and clean these things, not that it's the best way to practice, but we can. And so it really begs the question, what's the difference between a reusable and a disposable device? And why are we going towards all these disposables? So this is the principle of the circular economy. So the first thing we need to, what we have is a linear economy. So take, make, waste. So we take materials, we use them, and we eventually throw them away. The circular economy is about keeping materials in process within an ecosystem and designing out waste. So mostly we have to reduce our demand for resources, but we also have to use less materials and less energy intensive products. We have to extend the life and recover the materials, and we have to design out harmful emissions. So where do we go from here? We need to include environmental emissions in the total cost of ownership as part of our decision making as clinicians, as administrators, as regulators, part of the health and all policies, fundamental principle in public health. We need to frame public health as a matter of patient safety, quality, and value of care. So what we mean by patient safety also extends to public health. And accountability, which we didn't even get into, pay for performance. We have a whole article about this, and I invite you to go to it in Health Affairs, that basically says not only can we reduce our emissions, but we must be held accountable, and that can be done through the Centers for Medicare and Medicaid, through the Pay for Performance, which was part of the Affordable Care Act, designed to help us reduce emissions, but not reduce quality of care. And what we mean by value needs to be reevaluated. I mentioned the triple bottom line. It's the best care for the most patients at the least cost, but we also have to reduce environmental and social impacts. And so you've heard others say today, the Intergovernmental Panel on Climate Change and a special report on 1.5 degrees centigrade, basically saying that to avert the worst impacts from climate change by the end of the century, we need to get to net zero by 2050. We need to reduce our emissions by 45% by 2030. This is possible within the laws of physics, and it's really just a matter of political will. The National Health Service in the UK is setting an example. They're already reducing their emissions. They've got a whole unit dedicated to how we're going to get there and are starting to implement it. They know they can get there between 2040 and 2045, and I invite you to read their report as well. And so the connections between COVID and climate change is concept of flattening the curve. So the concept of flattening the curve is that by physical distancing, by hand washing, by mask wearing, it's not that we make COVID go away. But what we do is we spread out the contagion to the point, or spread out incidents so that we don't overwhelm the health system's capacity to care for patients. The same concept with climate change. We can't make it go away, but we can reduce our emissions to the point where we can improve our access to care and decrease demands and live within our capacity to take care of patients. The difference is we have a decade to get there, to get to that 45% reductions, which is sounded like a big deal. But now, since what we've accomplished, or at least attempted to accomplish in the past year, a decade is a lifetime. And so rather than have economic shutdown, we actually can have economic growth. Thank you very much for your time.